Hello, welcome to another session of our digital slide review and sign out. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center. I'm glad you joined me. I want to share with you today's case, which is from the realm of GYN pathology. The patient is a postmenopausal woman who's been discovered to have a unilateral ovarian mass. She has no other clinical symptoms and has generally been healthy, but has this fairly bulky mass, which the surgeon sends to us for frozen section evaluation. On dissection, we noticed that it was mostly solid, but had quite a bit of sort of oozy fluid, slightly mucoid, but not the typical mucinous multilocular cystic neoplasm that we see in many elderly patients. As you can see, there's quite a bit of glandular proliferation and a lot of open spaces here. Looking a little bit more closely, we can see that there's a little bit of debris in the mucinous spaces, and that most of these glands are fairly simple and have a tall columnar lining type cell with really quite a lot of apical mucinous type of epithelium or cytoplasm, and mostly basal-oriented nuclei, which are enlarged, a little bit pseudostratified, and slightly atypical, not really high grade. We do have a fair number of mitotic figures, so it's not at all difficult to say that this looks like a neoplasm. It's not just a mucinous cystadenoma with complexity by any means. But the cytoplasm here is a little bit pinker than usually in the either endocervical or enteric type of mucinous cystadenomas of the ovary that we would think of. So it raised the differential of, could this be an endometrioid tumor that has maybe a little bit of mucinous metaplasia? So that possibility was certainly something in our minds with this tall columnar appearance. Some grade 1 endometrioid tumors could certainly have this type of morphology. So we began to put together a differential and assemble a list of potential immunohistochemical stains that might help us. So one of the first ones we did was a PAX8, which was not very helpful. It was positive in a very few cells, very focally, not broadly in any of the areas of the tumor. We also did CK7 and CK20. And lo and behold, the CK20 showed a fair degree of positivity in many of the tumor cells, in contrast to the PAX8, which was largely negative. The CK7 was negative, again arguing against an endometrioid type of tumor. And we did a CDX2 marker, which was positive in most of these tumor cells. So this is a fairly classic enteric phenotype. And of course, that phenotype can occur in primary mucinous carcinomas of the ovary, but it also can occur in metastatic mucinous tumors to the ovary. So to help clarify that, we did a CDX2 stain, excuse me, not CDX2, we did that. We did a SAT-B2 stain to see if these would have a more specific enteric phenotype. And that was indeed positive in virtually all of the cells. That's again a nuclear marker and indicative of generally lower intestinal origin, appendix, colon, and so forth. That raises the question, well, is this truly a metastasis from the lower GI tract? Very well could be. But there's one other primary ovarian possibility, which is quite intriguing in light of the fact that this lesion is unilateral and contralateral to the appendix, where most of the appendiceal metastases tend to occur. So that possibility is the possibility that this is a somatic type of mucinous adenocarcinoma, low grade, that has potentially arisen from a teratoma. And that's the one situation where you can get a SATB2 positive primary ovarian mucinous carcinoma that has this true enteric phenotype rather than the mucinous cystadenocarcinomas with a enteric-like phenotype. So that presents an interesting differential and a challenge back to the clinical colleagues to either identify a primary. On our part, it did entail looking to make sure that we had not overlooked a minor component of mature teratoma, which we could not identify on any of the sections and ample sampling. So that's our final diagnosis on this case, is a mucinous adenocarcinoma, low grade, with an enteric phenotype, either due to metastasis from a GI primary or potentially a somatic type of mucinous carcinoma arising from a teratoma. So I hope you've enjoyed that case. It's a little bit challenging, a little bit unusual, and presents a very interesting differential for consideration. If you like this, please hit the like button and subscribe to our channel. We try to release things a couple of times a week so that there's always new material coming out as we learn things and share that with you, and as you have the opportunity to expand your skills in various areas of surgical pathology. So until next time, thanks so much for joining me.